Thanks for choosing products from Synovision. Today I will introduce the operation of liver perfusion analysis plugin. I will introduce from the below aspects: liver CT perfusion imaging principles, clinical significance, precautions, scanning interface introduction, and finally, we focus on introducing liver perfusion analysis post-processing software. Imaging principle. CT perfusion imaging was first proposed by Miles in 1991. It is a non-invasive method for imaging the perfusion status of organs and tissues. It is an important step for CT from morphological imaging to functional imaging. It is most commonly carried out by injecting the contrast agent intravenously, and then select the layer to perform the same layer dynamic scanning, to obtain the time density curve of each pixel on this layer, and use a certain mathematical model to calculate the perfusion parameters of the region of interest according to the curve, and the perfusion image is formed by assigning the color scale. Different from other single-source blood-supplied organs such as brain, kidney and spleen, the liver receives a blood supply from two sources: the hepatic artery and the hepatic portal vein. 20 to 40% of blood supply comes from hepatic artery, and 60 to 80% comes from portal vein. The changing of the ratio usually indicates the presence of lesions in the perfusion parameters. The hepatic arterial perfusion means hepatic arterial blood flow. The portal venous perfusion means portal vein blood flow. The total liver perfusion means total liver blood flow. The hepatic perfusion index can be understood as the ratio of the hepatic arterial perfusion to the total liver perfusion, and the portal perfusion index represents the ratio of the portal venous perfusion to the total liver perfusion. The time to peak can be understood as the time when the blood flow reaches the tissue. Various mathematical models can then be used to process the raw temporal data to ascertain quantitative information. Here we use the most classic one, the maximum slope method. Clinical significance. The perfusion imaging of the liver is still in the stage of clinical research. The current studies have revealed that CT perfusion imaging has certain significance in the early diagnosis of liver cirrhosis, liver cancer, and it's also helpful for the postoperative evaluation of interventional therapy for liver tumors, and for liver functional reserve estimation. Comparing normal liver tissues in compensated cirrhosis and decompensated cirrhosis, it was found that portal venous blood flow and total liver blood flow showed a downward trend, while the hepatic perfusion index and the time to peak have shown gradual increasing trends. And research showed that the portal perfusion index and the time to peak have high predictive validity for the cirrhosis. In the early diagnosis of liver fibrosis, the portal venous perfusion is the most valuable parameter. The studies of liver cancer have shown that the hepatic arterial perfusion and the hepatic perfusion index increased significantly, and the portal venous perfusion decreased, which may be related to the neovascularization of the tumor and the vascular density. According to this feature, it can also be used to distinguish the residual tumors and the cured tumors after the interventional treatment. Prior to the hepatic resection, the assessment of hepatic reserve is required. Current guidelines recommend standardized future liver remnant volumes is more than 25% in patients without any underlying liver disease. But because liver cancer is often accompanied by cirrhosis, so greater SFLR volumes are recommended for cirrhotic patients. As mentioned earlier, CT perfusion can be used to evaluate the intrahepatic microcirculation status of liver cirrhosis and fibrosis. Combined with SFLR, it's expected to have a more comprehensive assessment of liver function reserve. Precautions. CT perfusion is also a kind of enhanced scanning, so prepare for enhanced scanning, including refrain from eating for 8 hours, acute management of anaphylaxis, etc. Because of the requirements of CT perfusion algorithm, we need a high flow rate of the contrast agent, about 6 to 8 milliliter per s, and a 18 G or larger trocar needle have to be used. The contrast agent injection volume is 50 milliliter followed with 50 milliliter saline. The patient should breathe calmly during the scan, so the abdominal bands should be used to limit the breathing movement. Perform an abdomen CT scan before injecting contrast. To select the best perfusion scan level, including portal vein, spleen, and region of interest. The perfusion scan series parameters setting principles should include: use the widest collimation width. If the shuttle mode is available, then we can do whole liver perfusion. The thickness of the reconstruction should be thick and not thin, 5 to 10 mm. The scan cycle time represents the time resolution. The faster the better. 0.5 seconds to 2 seconds. Not more than 3 seconds. The delay time should not be too late. 5 to 8 seconds is recommended. The dynamic liver perfusion time should not be less than 60 seconds. Perfusion scan should pay special attention to the patient's radiation dose. 100 kV, 120 to 150 MAS are recommended. Scan interface. The scanning process is to scan the scout image first, and then perform an abdomen helical scan. Find the appropriate layer on the axial images, preferably including the cross-section of the portal vein, the region of interest, and then perform enhanced scan on this layer repeatedly. That is the so-called perfusion scan. Pay attention to the scout scan, non-contrast scan, and the perfusion scan all need to turn off the automatic voice. On Incidum 32 and 64S systems, we may see this interface. The blue human body picture is used for protocol selection. Select perfusion from the protocol group to enter the scanning interface. In the perfusion scan sequence, we can see that the scan mode is axial. The start scan position start is a fixed value. Pre-delay is set to 8 seconds. Cycle time is 2 seconds. The rotation time is 1 second. The number of exposure times, cycles, is 30 seconds. That is, after 8 seconds of injection. At the table position of 195.8, continuous exposure is carried out. After exposure for 1 second, the interval is 1 second. Exposure repeats again. A total of 30 times exposures are performed. That is, a total of 66 seconds were monitored after the injection of the contrast medium. On the 3.0 Rainbow platform, the parameter layout is slightly different, but the meaning of the parameters is exactly the same. After the scan is completed, the perfusion enhanced images should be transmitted to the post-processing workstation for liver perfusion analysis and processing. Below we will focus on the post-processing analysis. After selecting the perfusion sequence, load it into the liver perfusion analysis application interface. The pop-up window prompts that the application results are not the only basis for diagnosis. Click OK to close the pop-up window. At this time, the left side of the interface is the image view, and the right side is the toolbar. The perfusion analysis process is generally divided into 3 steps. The first step, data correction. The second step, blood vessel definition. The third step, measurement and analysis. Now we are in the first step, data correction, which is mainly to remove images that do not meet the requirements, such as images with excessive artifacts or obviously deviated. On the left side of the view window are axial images, and the right side are the overlapped images of all time periods on the current layer, displayed in the form of maximum intensity projection. First of all, we have to adjust the window with N window level to observe the image more clearly. Drag the slider to perform a dynamic observation at the same layer but at different times. The blue number below represents the current layer sorted by time. 15 means the 15th acquired image. It can also be automatically played by pressing playing. During the playing, we can clearly observe the effect of the respiratory movement on different perfusion images. Slide the bar at the bottom or flick the triangles at both ends to switch layers. The blue number on the left side shows that the perfusion covers a total of 4 layers. The number in front of the slash is the current layer. At the top of the toolbar are common tools for perfusion analysis, including image alignment, which can correct and align slightly misaligned images. Image smoothing, smoothing the image to reduce image noise. Smooth settings, to set the method and times of image smoothing. Below is the sequence editing. If you want to delete an image with a lot of interference, for example, there are 30 images in layer 1, and we want to delete the 29th image. Select the 29th image. Click Add the image to be deleted to mark it, and then click Generate New Series. Now in the new series, the selected images have been deleted, and only 29 images remain. Histogram in the toolbar can be used to extract tissues by setting the threshold. Means only the tissues within the threshold can be used for subsequent calculations, which are mostly used in brain perfusion imaging. Through the above-mentioned operations, alignment and deletion and so on, we have completed the first step of data correction. Press the next arrow to enter the vessel definition interface. The lower left corner of the interface will display the time density curve. We can use these tools to define the hepatic artery, portal vein, and spleen tissue. Because the hepatic artery is thin and small, so we can use the aorta that is close to the hepatic artery. After adding, the red time density curve of the aorta can be seen in the lower left view. Then add the portal vein as a blue curve. In order to reduce the interference of respiratory motion, try to select the portal vein that is in up and down direction, and use single define portal vein. Right-click to delete the definition. The ROI is allowed to be placed on different layers. Find out the portal vein that is in an up and down direction. Then place the ROI. It can achieve a smoother portal vein curve. Place the last ROI on the spleen to generate a yellow spleen TDC. Throughout the definition process, you must pay attention to breathing disturbances, and try to ensure that the curve is smooth. SP and EP represent the start and end phases respectively. You can pull them by dragging the arrow. The red SP must be placed on the last image before the hepatic artery starts to enhance. The peak of the spleen curve usually represents the end of hepatic artery perfusion and the beginning of portal vein perfusion. So the yellow max line must be placed at the peak of the spleen TDC. Press the next arrow to enter the measurement and analysis interface. At this time, the color-coded CT perfusion maps, parametric maps, are displayed at the upper right, and at the bottom is the quantitative values display area. Double-click the color map images to display in full screen. They are as follows: hepatic arterial perfusion, portal venous perfusion, total liver perfusion, hepatic perfusion index, portal perfusion index, and time to peak. Hold down the middle mouse button and slide to adjust the color effect. Double-click the color scale to change color protocol. or only display a single color map image. Double-click again to return to the original layout. Both the grayscale image and the time density curve window can be double-clicked to switch the full screen. Fusion display. The grayscale image can be fused with the parametric maps to locate the lesions more easily. By default, the grayscale image will be fused with the hepatic artery perfusion parametric map. Right-click the blue text HAP to switch to other perfusion parametric maps. On the left side of each parametric map, there is a color scale. The lower color indicates a lower value, and the upper color indicates a higher value. For example, in the HAP parametric map, yellow indicates a higher value of hepatic artery perfusion than blue. It can be seen at the liver tumor border that hepatic artery perfusion, total liver perfusion, and hepatic perfusion index are significantly higher than normal liver tissues, while portal perfusion index is lower than normal liver tissues. Time to peak is significantly shorter. In the central area of the tumor with reduced perfusion, the hepatic perfusion index is significantly higher than that of normal tissues. Next, we respectively place the circular or polygonal ROI on the tumor center, tumor border, and normal liver tissue. When placing the polygonal ROI, right-click to end the drawing. Note that blood vessels should be avoided when placing any ROI. The measured value are displayed in the perfusion parameter table. It can quantitatively reflect changes. Finally, we can save the parameter map, TDC, and quantitative measurement table. The system will automatically save all results in a sequence. The introduction is stopped here. I hope you find it helpful to understand the use of liver CT perfusion analysis software.